Welcome to Didactic Residency Edition. I am Dr. O'Leary, a fourth-year psychiatry resident in the National Capital Region. This podcast is my own venture. I really hope by having to put together some kind of coherent product, I'll increase my own knowledge and my own competence. I try to report true and up-to-date information for you, the listener, but in the end, everything I say here is really just my own opinion. It shouldn't be confused with the opinion of my residency or any other governing body, such as like the Defense Health Agency or the U.S. federal government. Today, I will talk about psychological and neuropsychological testing. I should also warn you that I'm not a psychologist. I hope soon to be a board-certified psychiatrist. It appears likely to me that I will pass my boards and be dubbed a real psychiatrist, but that won't happen until more than 1 year from now, if ever. Many of my patients are confused by the difference between psychology and psychiatry, or especially neuropsychology and neuropsychiatry. To be honest, I'm also unclear as to what the credentials of many of my colleagues are, especially because every provider in our clinic tends to focus on the kinds of therapies or treatments that they feel most comfortable with or were most attracted to. Another thing that has been difficult for me to parse in my own mind is what are the differences between psychological and neuropsychological testing. If I were to try to give a quick one-liner, I might say that neuropsychological testing is concerned more with how the brain is malfunctioning, and psychological testing is concerned more with how to measure and predict human behavior when we don't necessarily have an idea or a good idea about how that behavior is related to brain function. I don't think that anything that I just said really is very satisfying or has answered the question, who do I refer to? In part because the way that we've kind of historically divided behavior from brain function is really messy, though kind of understandable given that the brain is so complex, and we have only in the last few decades begun to parse some of this out. So let's go ahead now and take a deep breath and another drink of your coffee. So what I'm going to focus on for the rest of this episode is how to decide whether to send a patient to get neuropsychological or just psychological testing. And this decision is kind of determined by at least two important things. The first is the question that you're trying to answer. If you don't know what the clinical question is, then you should discuss the case with a psychologist and a neuropsychologist and see if they have any suggestions for you as to what might be helpful to ask. The second consideration is, what can the service that I'm referring to actually provide for the patient? As a referring provider, then, it's really helpful to know what kinds of tests a psychologist or a neuropsychologist can administer, because these are designed to answer very specific questions. My last episode was concerned primarily with the term validity, and basically this means that a test is measuring something real and hopefully is only measuring that thing, and that it's designed to measure, not other things at the same time accidentally. So every test is concerned with one or more constructs. One of the most common kinds of tests that psychologists administer are tests of personality or inventories of personality. These are given for many different reasons. Someone may be interested in what kind of a career field they might find more rewarding or intuitive for them. A psychiatrist may suspect an underlying personality trait or traits that might be exacerbating a patient's symptoms or contributing to treatment resistance. For example, a morally rigid person may not be very receptive to cognitive behavioral therapy, which often challenges a person's thoughts and beliefs. Although that might be exactly what the patient needs, they're just not receptive to it. Psychological testing might help predict responses to various kinds of therapies, or explain why they haven't been making progress. Also, companies might want to predict what job candidates might perform better in certain positions, so they might want personality inventories. It's important to note that the results of these tests cannot actually predict the future. But what they do is they place the test taker, given their results, into a distribution within a population of other folks that are kind of like them. And they look to see if this person's responses on certain items in aggregate are within 1 or 2 standard deviations from the mean. Are they normal? If they're outside of the range, then they are different from most people. The population they're compared to might include factors such as age, level of education, sex or gender, race, or other ethnic considerations or characteristics. Even if they are not outside, say, 2 standard deviations, but they have some personality characteristics that can affect their current presentation, these are still important to identify. It can be difficult sometimes when a psychiatrist suspects a personality disorder to fit a patient into a single DSM-like entity. Personalities are more complex and they don't play by the rules. Personality tests might be able to identify traits that are pathological or in combination with a few other traits that aren't quite outside of the 2 standard deviations but are all like near the edge, might result in a pathological condition within the individual, a lot of dysfunction for them. Then the psychiatrist might discuss with the patient that they have a personality disorder even though this disorder doesn't fit cleanly into DSM categories. And then they can focus on treatment based on those identified personality traits. These personality inventories may also contain measures of things like anxiety or depression or obsessiveness, or identify things like their interpersonal styles. And that can help explain how the respondent might interact with others. There may also be items that estimate a person's risk of suicide or violence toward others. Before referring a patient for testing, be sure to let the patient know that some of these tests might be long and really exhausting. I mean, some of them take hours and hours to complete. For some of the longer testing batteries, there are even measures to see if the respondent's effort kind of drops off in the last part of the test. Another helpful tool in many of the tests are items that help estimate whether the individual tends to over or under-report the severity of their symptoms. So I've heard the term cry for help used when someone is kind of measurably over-reporting their symptoms, but I'm not exactly sure what that means. There are patients whose overall distress due to their current life circumstances or their personality features kind of results in them circling the highest number on every measure because their level of distress really just short circuits their careful consideration of the test item itself. They're just like, I'm bad, bad, it's as bad as it can be. There are also patients who really consistently under-report symptoms for whatever reason. It could be maybe a lack of insight into their dysfunction or a lack of familiarity with the words used for the test or a fear that they may be kind of exposed and punished or limited in their employment or other areas of their life if they actually report accurately what they feel. For people who were raised in families that really didn't talk about feelings and emotions, it may be difficult for them to even conceptualize what sadness or anxiety are. I've had patients who have just denied anxiety every time they're asked on the screeners, and then when you directly say, are you an anxious person or do you worry a lot? But then when you ask more questions, you find out that when they try to sleep, they can't stop thinking about whether or not what they said might have offended someone, or if they're competent enough, or if their family is safe. And they just don't know that that's worrying. Most personality inventories require a patient to self-report items on a scale. So this is often like a Likert scale where people rate the severity of their symptoms, or they rate like their agreement with a statement, and there's like 5 options on the scale. It might be something like, this is not at all like me for the first option, and the last option would be, this is very much like me. Or the first option might be, I strongly disagree, and the last one might be, I strongly agree. The third or the middle option on this scale is often something kind of neutral, or 0. There are also tests that a psychologist scores for the patient. They also require, because the psychologist is scoring it for the patient, the psychologist requires more specialized training to administer the test so that they can really understand what the patient's responses mean and how to score them. Probably the most famous of these tests is the Rorschach ink blot. The examiner has to be very careful about how they ask questions and how the patient responds, so that they can interpret those responses reliably based on kind of an already set possible kinds of answers and then their own clinical judgment. In the Rorschach test, people are shown a standardized set of ink blot cards, and they respond in a very structured way, which includes a chance for the respondent to point to the card and justify their answer. I don't have time here to get into the specifics, and I don't really understand the specifics myself because I've never administered the test. But one of the reasons a patient may be referred for a Rorschach test is to help identify whether or not they have like a thought disorder. Are their responses related to the shape itself or kind of more internally derived? Do they give logical justifications for why they gave a certain response? Do they use the whole card or just a small portion of it? I imagine that something like this might be helpful when a clinician is trying to distinguish between, say, some cluster A personality traits, like patients who are paranoid or has schizoid traits or schizotypal traits. And you wonder if this is the result of a psychotic process. Odd or infrequent responses don't by themselves indicate a thought disorder, but if a patient's explanations for this don't make sense to the examiner, and this happens like multiple times, then a thought disorder is really more likely. There are subscales calculated that kind of give scores that help the person administering the test to interpret the results of the test. Another kind of more objectively scored test is the thematic apperception test. This test also uses a set of cards, but instead of ink blots, they have pictures of people who are participating in some kind of like social interaction, and that interaction is designed to be ambiguous. By that, I mean that the cards can be interpreted in multiple really legitimate ways. The way a person interprets the card determines their scores on various derived measures. One of these is called the Social Cognitions and Object Relation Scale. The various parts of this scale might reveal features of the respondent, such as whether they are able to see other human beings as having kind of a complex internal life themselves, or if they can identify that people often have contradictory features, like humans really have. Or if they see others as being very simple, like they're kind of all good or all bad. With so much rich information from these cards, a psychologist can possibly identify things like a person's level of emotional response, their own interpersonal style, and how they might relate to others, including, like, for example, their psychotherapists. And you may be able to see whether in general this patient sees the world as kind of threatening or more benevolent or welcoming. Aside from exploring the depths of someone's personality and emotional life, psychological testing is also famous for attempts to measure intelligence in the form of an intelligence quotient, or IQ. These tests are still widely used today. I've had people tell me that they took an IQ test online and it showed that they were a super genius, so this must explain why they don't relate well to other people. Well, this misunderstood genius has fundamentally misunderstood the validity and reliability of the test that they took. I doubt any random IQ test online that someone takes at home is very reliable or valid, even if it was derived from other validated tools. There are some common misperceptions of IQ tests. One is that IQ is a single thing, that it kind of defines a person's intelligence. And it tries to, but it's not one thing. There are multiple measurements that go into calculating an overall IQ. And these subscores may be very different from each other. In what's called like the Wechsler series, there's, for IQ, there's verbal comprehension, perceptual reasoning, working memory, and processing speed, and all these contribute to that overall intelligence quotient. Someone may have a large difference between their verbal and perceptual abilities, and the average of the two may, by itself, actually not be that meaningful. The difference between them would be more meaningful than the average. So what I've read, it's really expected that all of the components of an IQ should fall within one standard deviation of each other. And if they're outside of this, then that really should be noted on the testing. And further testing might be necessary to figure out why. Another common misconception about an IQ is that it is permanent, an immutable feature of a person. And this is simply not true. An IQ can change over time for, well, at least two reasons. One is that the person's abilities have changed. Say they've become more educated or more practiced, and they've just improved. Their brains got better. The brain is an adaptive organ. Another reason that an IQ could change is that the group that the individual is being compared to during the test actually changes. If an individual does not change in their own ability, but now they're in a different group with its own kind of means and standard deviations, then the IQ will change because it's measured against the group, other people's performance. A clinical situation in which an IQ might be helpful is determining, say, if someone has extremely limited abilities or borderline intellectual functioning. This can have all sorts of prognostic and legal implications, such as whether a person needs a legal guardian, and it can help to determine what kinds, if any, therapies the patient can respond to. I mentioned earlier that one of the objectives of this episode is to distinguish between whether a patient needs referral to a psychological or neuropsychological testing. And there can be a lot of overlap between the two. Both can be concerned with emotion, cognition, and behavior, with memory and processing speed. So in general, neuropsychologists are concerned with a patient population that often already has identifiable brain impairments or reasons that they might have those due to things like neurodevelopmental disorders like autism or ADHD, or acquired disorders like stroke or dementia, say multiple sclerosis, traumatic brain injury, autoimmune encephalitis, diffuse hypoxia, diffuse axonal injury, among other things. Neuropsychologists were initially primarily experts in taking a clinical picture and then trying to localize where the dysfunction in the brain was. And actually, they're still experts at this. However, they get a lot of help now. I mean, we have advanced neuroimaging, such as magnetic resonance imaging, or functional magnetic resonance imaging, positron emission tomography, or PET scans. There's single photon emission computerized tomography, or SPECT, and magnetoencephalography. And I'm not sure when they put it together as MEG, whether they pronounce it MEG or MEG. Like as a med student when I said the bun instead of the bun and was castigated for it. A neuropsychologist can use like imaging like this to guide what kinds of exams or tests they need to perform, or they can use the clinical picture to recommend what kinds of imaging is needed. In our modern times, most of the patients that will be referred to a neuropsychologist for testing will already have a diagnosis. They may have Huntington's disease or a frontal lobe injury or an MCA stroke or a history of temporal lobe seizures or like ADHD or autism with some associated features that really need more investigation. Testing in these cases can be helpful to establish like current levels of dysfunction, especially for progressive illnesses or other unrecognized defects. And the neuropsychologist can recommend treatments or more investigations if it's needed. Patients with acquired issues can be especially difficult. I mean, it would be ideal for a neuropsychologist to have testing before and after the injury, but usually the testing before the injury isn't there because they didn't need testing, right? If they had that, the testing could potentially reveal changes in the individual from their premorbid condition. Tests administered by neuropsychologists are just like the ones by psychologists in that they're normed on population data. But just because an individual scores within the normal range, that doesn't mean that their own abilities have not been compromised by something. So I can imagine someone who initially had like very high processing speed and then scored below average, but still within the normal range. This would, if we had the testing before, represent a large change for them. This is a loss of ability for them to do things that they could do before. They might now need some kind of assistance or training to learn new skills to accomplish the same tasks they were able to easily accomplish before. That's going to be a huge change for them in their life, even though they fall out in the normal part of the range. Neuropsychological testing kind of expands what basic psychological testing is sensitive for. So IQ, for instance, can be very informative for someone who is otherwise normal, but for individuals with specific brain impairments, it might not be that helpful. Neuropsychological tests add different domains, things like attention, executive functioning, memory, language abilities, perception and processing of visual information and other sensory information, motor function, and also considers aspects of emotion and personality that are especially affected by specific pathologies. And these pathologies might make normal kind of personality inventories not as useful for patients. You may have used the Montreal Cognitive Assessment, or MoCA for short, or the Mini Mental Status Exam in your clinical practice. So these can be used as kind of screening tools for dementia, or at times as kind of convenience measures to track a patient's progress, like whether they're worsening or stable. Tests administered by neuropsychologists are more useful at identifying and measuring the very, very specific neurological abilities or lack thereof of a patient. I've often had difficulty explaining to my patients kind of what executive functions are in their brain because, well, that's such a broad term. I mean, I often mention that it has to do with the front part of the brain and their ability to, like, sort through important information about their near and distant past, kind of apply it to the present, and plan for the future. But this is very vague. Neuropsychologists can test for frontal lobe functions by measuring things like social intelligence, which basically means a person's ability to recognize their social environment and act appropriately within it, and like regulate emotions and inhibit their impulses. Like, don't punch that person in the face. Instead, it's best if you just remove yourself from the situation. Maintaining attention is an executive function. The frontal lobes are one of the locations that affect our ability to maintain attention. A lesser known but even more important task is the ability to kind of initiate some kind of behavior. The frontal lobes help out with that as well. Like patients with catatonia often kind of appear stuck, as if they're trying to do something, but just can't complete the action, or they can't stop doing or saying something because they can't switch to or initiate something new. That's called perseveration, and I did in a word on that previously. This often has something to do with a frontal lobe dysfunction. The frontal lobes help us kind of switch away from a focus of attention and then return to it. One of the common aspects of ADHD is not only that they're kind of switching their attention too frequently, but also that they might not be able to switch their attention easily when they need to. This is often called like hyperfocus, and it can be seen as like a deficit in what is called cognitive flexibility. You really can't expect a child with ADHD to respond immediately after they receive a request. They really need some time to process the information and to make the switch. The switches that they're making are more involuntary. To make a voluntary switch is difficult for them. I've heard colloquially people report that because they can multitask, which actually is just task switching and not multitasking, that they must have ADHD. But the opposite is in fact true. Those with ADHD have a very difficult time, quote, multitasking, unquote. But it might appear as if they are multitasking because they're task switching, but they're often not doing that in an efficient or optimal or voluntary way. Our executive functions are frontal lobe functions, but they really require more connectivity with other regions of the brain, deeper regions, in order to work. They don't exist only in the frontal lobes. The frontal lobes are necessary, though, for them. So I've mentioned that there's the corticostriatal thalamocortical tract in past episodes. So like tracts originating in the dorsolateral prefrontal cortex are necessary for like planning and controlling impulses. Tracts that include the lateral orbitofrontal circuit are more involved in social intelligence. There are also systems that process rewards and motivations, and that includes the anterior cingulate cortex, and this connects, like, for example, to the nucleus accumbens. Particular deficits identified on testing can help to locate where the dysfunction is occurring, and it can help to target interventions, whether it be like therapy, drugs, transcranial magnetic stimulation, or kind of when all else fails, deep brain stimulation or like gamma knife radio ablation of certain out-of-control regions of the brain. Personality changes often accompany damage to the frontal lobe. Traumatic brain injuries and frontotemporal dementia are like classic examples of this. These changes are better characterized with neuropsychological testing than with regular psychological testing because they don't represent kind of the same kind of pathological personality traits that are captured with psychological testing, because psychological testing is normed more on the healthy population, but what we are interested in is people with TBIs or people with frontotemporal dementia. Another aspect of frontal lobe function that neuropsychologists measure is something called concept formation and reasoning. This deals with being able to do things like interpret a proverb or to apply rules. Often they'll have patients do like sorting tasks, and they'll see if the patient is able to change their strategy when the rules change. There may also be tasks that do not require the use of language. Maybe there's a problem with language, but they don't actually have a problem reasoning in other ways, like spatial, abstract, numerical. These are all kind of different kinds of things that make us able to interact with our physical environment effectively, even if we can't communicate using language well. Memory is another important construct that neuropsychologists test. It's far more complex than it appears on the surface. It's not only like anterograde or retrograde memory loss. the former being the inability to make new memories, and the latter being the inability to recall previous memories. We have lots of possible defects in our memory. We have short-term memory, we have working memory and long-term memory, and there can be defects in any of those. We also encode memories a little differently depending on what sensation it is. So we might have specific deficiencies in verbal or auditory memory, but not so much in spatial memory formation or retrieval. Neuropsychological testing can really help identify specific problems and help to localize where these problems are. Language abilities, as I mentioned earlier, are a large part of neuropsychological testing. There are many kinds of aphasias, or inability to speak or use language. There's receptive or expressive aphasias. There's fluent and non-fluent aphasias. There's primary or secondary aphasias. There's mixed aphasias. There's primary progressive aphasia. Now, it's beyond the scope of this episode to discuss these in particular, but if you're concerned about language abilities, then neuropsychological testing is something that can be very helpful. There are also many ways to test the ability of a person to process visual information. Perceiving visual information is more than just kind of receiving a signal from the optic nerve. The brain needs to be able to identify what it sees, and whether that is an object or a face, or whether it contains information like emotional expressions. It's also critical to be able to have a concept of where something is in space, in relationship, say, to the self and to the objects around it. Often neuropsychologists can start determining if someone has visual problems or visual processing issues by giving a patient a visual constructive test. You can ask them to draw various objects. It can be something simple, like a geometric shape, triangles, circles, rectangles, or it could be far more complex figures that they have to draw that have lots of lines and asymmetry. The MOCA, if you've ever administered it, you know that it contains a box drawing where they have to draw a three-dimensional box and a clock. If the patients fail at construction tests, then other tests can be used to figure out where is the problem? Is it visuospatial, or is it perceptual? Neuropsychologists can also help provide us with insight regarding kind of a patient's emotional or behavioral issues. For patients who seem to be over-reporting their level of dysfunction, or who are excessively worried about memory or other cognitive type issues, simply knowing that a patient tends to over-report on scales is actually not that helpful, because we don't really know specifically that some of the things that appear to be over-reported are not actually over-reported. So neuropsychiatric testing can provide objective information that can confirm whether the patient's perception of their deficit actually matches with the measurement of their deficit. And these tests also have some measures of effort built in. So if the respondent doesn't actually appear to be giving their best effort, then this can be reported and the test results be invalidated. This episode has gotten very long compared to what I normally do. I try to keep my episodes less than 30 minutes and 20 minutes if I can. The question that I used to guide this episode was, when will I know whether I should refer a patient to psychological or neuropsychological testing? And I hope that what I've just discussed can help you better conceptualize the answer to that. And here are some brief takeaways for this question. Or maybe they should be more brief than they're going to be. So if you're concerned primarily about diagnostic clarity with regard to symptoms, when you feel like there's personality traits that may be confounding mood disorders or psychotic disorders or anxiety, or there's obsessional traits, or you think that a patient may be systematically over or under reporting their symptoms, then regular psychological testing can have a lot of value. I'm not sure why or when a psychiatry resident would be interested in primarily just a patient's IQ, then you could refer just for IQ testing, and that could be to a psychologist. It doesn't need to be a neuropsychologist. You might be interested in IQ, but more interested in like processing speed in particular, or memory function, because a patient of yours suddenly finds it difficult to perform certain cognitive tasks after a traumatic brain injury, and you'd like to get kind of a baseline of how they are now to be able to track their progress, whether or not they're getting better or getting worse or staying the same. In general, if any cognitive, emotional, sensory, or behavioral symptoms appeared or worsened after some kind of acquired injury or illness, neuropsychological testing is the way to go. A neuropsychologist can also administer any tests that a psychologist can, so you're not really leaving anything out if you go to a neuropsychologist. However, you often don't need those additional battery of tests that a neuropsychologist can give, so you can just send them to a psychologist. When in doubt, write down your question and then call a psychologist or a neuropsychologist and ask them what to do. If you don't know your question yet, then write up a thorough case summary and then call a friend and discuss the case. I want to end this episode by giving you a sense of immense dissatisfaction. I'm going to apologize ahead of time for this, but I think it's important to point out when there are not easy answers to the question like, do I send this person for psychological testing or neuropsychological testing? One of the difficult things to diagnose is ADHD in an adult. There are clinical screening instruments like the ASRS or the WIRS, and you can look those up if you want. They can help estimate current symptom burden or past symptom burden in a patient, symptoms they had in childhood. You might get collateral, but that collateral information might be contradictory. Quite often, someone is coming in when they've kind of reached a point in their life where they find it hard to juggle so many things, but when you look at their past, they kind of seem to do, well, adequate in school and work before. We know that highly intelligent individuals may be able to compensate for their ADHD, maybe by having fast processing speed or good memories, or they just spend like excessive amounts of time doing things, accomplishing tasks. Someone may also have been raised in an environment where their parents were kind of extra involved, so they didn't see their dysfunction until mom and dad sort of withdrew their constant support. Or maybe they didn't learn the skills to organize themselves because mom always did that for them. Maybe they came from a school that was lower performing and kind of inflated their grades so as to make it seem like they were achieving more than they really were. I mean, it is tempting to assume that with difficult adult ADHD cases, you can just refer for neuropsychological testing, and that will give you clarity. But none of the tests that neuropsychologists or psychologists can add on are specifically designed for diagnosing ADHD. Even the attention-specific tests given by neuropsychologists are not tests for ADHD. They are tests that can identify certain deficits in attentional capacity, but without a clear clinical picture, prior testing, some kind of insult or injury to explain the results. Like, these tests are not necessarily helpful. You need a much larger picture. ADHD remains a clinical diagnosis. I read on one website that all children or all individuals diagnosed with ADHD should undergo neuropsychological testing. It just happened to be a clinic that does that. So they have like a financial incentive to have everyone sent for neuropsychological testing. But that's not necessarily the case. It does not necessarily help you diagnose the patient. And if the patient responds well to stimulants, you don't necessarily have to look for a lot of other things. So the dissatisfaction part is that I'm not going to answer whether or not you should send a patient that you're struggling with, diagnosing with ADHD, to a neuropsychological testing. I don't think it's necessarily all that helpful. You have to have a very specific question that you want to answer, and often that question can't be answered by that test. Well, good luck. I told you I would leave you dissatisfied. But I hope that this review of what kinds of questions psychological and neuropsychological testing can answer is still helpful. I mean, it's helped me better understand what I'm doing when I place a referral. Thank you for listening. I am Dr. O'Leary, and this has been an episode of Psydactic Residency Edition.